This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level of healthcare pros. Today, we're looking at the cortisol-insulin axis. It's a fundamental regulatory network that governs how energy substrates are partitioned in the human body. We're going to connect these abstract molecular pathways directly to patient care, keeping our focus on the physiological mechanisms that drive metabolic health and disease. Here's a quick look at our roadmap. We'll start with a clinical case, walk through normal physiology, dive into the pathophysiology and diagnostics, look at treatments, and finally, integrate all of this across our body's systems.
Let's start with part 1, our clinical case. Meet Sam. She's a 27-year-old Latina night shift nurse who's been working in the intensive care unit for about 5 years now. Statistically speaking, shift workers and folks in high-stress, sleep-disrupted clinical roles like hers represent a population at a significantly higher risk for metabolic syndrome. Honestly, Sam's story is a very common one that you'll likely encounter in practice.
When we assess Sam, we start seeing some early clinical signs. Her fasting glucose is sitting at 108 milligrams per deciliter, which puts her right in that pre-diabetic range. She also reports rapid abdominal weight gain and tells us she constantly feels wired but exhausted. Now, these symptoms aren't just random. Sam's chronic stress and the profound sleep disruption from those night shifts have already kicked off a significant hormonal imbalance, way before any onset of overt diabetes.
Moving gently into part 2, normal physiology. To really understand what's happening to Sam, we have to review the basics of the HPA axis. That's the hypothalamic-pituitary-adrenal axis. It's the neuroendocrine system responsible for regulating our body's response to stress and keeping our metabolism in check.
Let's walk through the normal HPA cascade step by step. First up, the hypothalamus releases corticotropin-releasing hormone, or CRH. This tells the anterior pituitary to secrete adrenocorticotropic hormone, ACTH. ACTH then travels down to the adrenal glands, specifically targeting the zona fasciculata of the adrenal cortex to synthesize and release cortisol. In a perfectly healthy state, that elevated circulating cortisol creates a negative feedback loop. It actually inhibits any further release of CRH and ACTH, which keeps everything in perfect physiological balance.
This table elegantly contrasts the molecular actions of cortisol, which is our energy-mobilizing catabolic hormone, right against insulin, our anabolic storage-promoting hormone. In the liver, cortisol activates gluconeogenesis enzymes like PEPCK to push more glucose out, while insulin suppresses them. Down in the skeletal muscle, cortisol actually inhibits the movement of GLUT4 to the cell membrane, effectively blocking glucose from entering, whereas insulin stimulates it. And in adipose tissue, cortisol promotes lipolysis but uniquely targets visceral fat for deposition, while insulin promotes overall fat storage across the board.
That brings us to Section 3, Pathophysiology and Symptoms. We're going to shift seamlessly into the core problem here and detail exactly what goes wrong at the cellular level when the HPA axis is continuously activated. It creates this fascinating phenomenon we call the cellular tug-of-war.
You see, cortisol has a profound biological duality. In an acute, high-demand situation, think of a marathon runner experiencing hypoglycemia, cortisol acts as a metabolic hero. It suppresses insulin to keep that newly produced glucose circulating in the bloodstream, literally rescuing the brain from an energy crash. But under chronic stress, much like Sam's endless night shifts, cortisol becomes a metabolic villain. That sustained elevation causes chronic insulin receptor antagonism. So a mechanism designed to save your life turns into a pretty destructive physiological force.
Let's break down this pathophysiological chain reaction. First, sustained cortisol elevation from things like sleep deprivation directly causes cellular insulin resistance by suppressing GLUT4 in your muscle and fat cells. Because those cellular doors are essentially locked, blood glucose stays high. The pancreas senses this and goes into absolute overdrive, resulting in compensatory hyperinsulinemia. And when you combine that excess insulin with high cortisol, it strongly drives targeted visceral fat storage.
So now we can directly link Sam's specific symptoms back to this underlying cellular dysfunction. Visceral adipocytes, those are the fat cells in the abdomen, are highly sensitive to cortisol. Because of that, the body preferentially directs fat straight to the belly. The insulin resistance perfectly explains her elevated fasting glucose of 108, and that overactive HPA axis is absolutely contributing to her rising blood pressure. If this hormonal tug-of-war is allowed to continue, we start seeing severe complications. Chronic hyperinsulinemia actually drives even more HPA axis activation, which creates this terrible vicious cycle. And the pancreas just can't overproduce insulin forever. Eventually, progressive beta cell exhaustion sets in. When you couple that with the systemic inflammation coming from all that accumulating visceral fat, the patient transitions from merely being insulin resistant right into overt type 2 diabetes. Okay, let's move calmly into Section 4, Diagnosis and Genetics. In so many difficult-to-control type 2 diabetes cases, subclinical hypercortisolism is the hidden driver. Knowing how to identify this clinically is just paramount for us as advanced healthcare professionals.
I really want you to note this critical clinical threshold, 1.8 micrograms per deciliter. We use this specific cutoff during a 1 milligram overnight dexamethasone suppression test. If your patient's morning serum cortisol is not suppressed below this level, it's a very strong indicator of hypercortisolism.
The precise diagnostic workflow starts with that 1 milligram overnight dexamethasone suppression test. If those results are elevated, we then measure morning plasma ACTH to localize the source. We need to know if it's coming from the pituitary or the adrenal gland. If ACTH is low, we utilize adrenal CT imaging to hunt for adrenal adenomas. And of course, throughout this whole process, it's absolutely critical to rule out any exogenous steroid use, since that can completely mimic these exact metabolic effects.
On a genetic and molecular level, we also have to consider the enzyme 11-beta-hydroxysteroid dehydrogenase type 1. When there are mutations or even just an enhanced expression of this enzyme, it increases the local conversion of inactive cortisone into active cortisol, right inside peripheral tissues like the liver and adipose tissue. This essentially increases local tissue sensitivity to cortisol and drives visceral obesity, completely independent of whatever the circulating adrenal cortisol levels might be.
Transitioning now to Section 5, Treatment and Systems Integration. We'll look at how clinical treatments work physiologically to counteract this axis, keeping our focus firmly on the mechanism of action.
Take a moment to look at this clinical data on mifepristone, which you might know as Korlym. Mifepristone acts as a competitive glucocorticoid receptor antagonist. It literally blocks cortisol's metabolic effects right at the receptor level. In this particular case series of patients dealing with hard-to-control diabetes driven by hypercortisolism, blocking that receptor resulted in 9 out of 10 patients losing weight and 8 out of 10 experiencing significant drops in blood pressure, all alongside massive improvements in their overall glycemic control.
We also have other frontline medications that physiologically counteract cortisol-induced insulin resistance in slightly different ways. GLP-1 receptor agonists are great because they restore the incretin signaling and insulin secretion that cortisol suppresses. SGLT2 inhibitors lower plasma glucose by inducing renal excretion, which entirely bypasses the peripheral GLUT4 blockade that cortisol imposed. And finally, metformin. It directly opposes cortisol's primary action in the liver by reducing hepatic gluconeogenesis.
When we integrate all of this into the 11 organ systems, remember our trusty acronym MRS includer, we can clearly see that HPA axis disruption has vast systemic effects, well beyond the endocrine and muscular systems we've talked about. Chronic cortisol elevation severely impacts the cardiovascular system by driving hypertension. It also affects the nervous system by altering mood and cognition. And remarkably, it even impacts the digestive system by driving gut microbiome dysbiosis, which just further promotes systemic inflammation. Finally, we arrive at Section 6, our summary. Let's do a concise recap and tie all these molecular concepts right back to patient care.
To summarize, under normal conditions, the HPA axis regulates our energy mobilization perfectly via cortisol. But in pathophysiology, chronic stress causes a sustained cortisol elevation, which antagonizes insulin at the cellular level. Clinically, we see this present as visceral weight gain and elevated glucose, just like we saw with Sam's 108 milligrams per deciliter. And for treatment, logic dictates that we either directly block the glucocorticoid receptors with agents like mifepristone, or we strategically bypass the resistance with medications like SGLT2 inhibitors and metformin. I want you to really reflect on this profound biological duality. The exact same hormonal axis that saves a fasting runner from hypoglycemia can also drive severe metabolic disease in a chronically stressed nurse. Truly understanding this on a molecular level changes the entire landscape of how we approach patient care.
So, I'll leave you with this final provocative thought. Could unrecognized hypercortisolism be the underlying driver in your most difficult-to-control type 2 diabetes cases? Keep this pathway in mind the next time you assess your patients. Stay patho-curious and see you next episode. Please note, A&P Live Studio is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.